Peter Brucker, Dr. Peter Brucker from Munich. He will talk about the role of modern injectable in high-performance sports like football or skiing, together with his colleague. And at first, I want to introduce to you Dr. Brucker, and then I will introduce to you Dr. Doyscher. So Dr. Brucker is an internationally renowned sports orthopedic specialist with focus on minimally invasive and regenerative and reconstructive knee surgeries, muscle tendon surgery, and the lower extremity and orthobiological sports medicine. He is a leading team physician of the German ski national team, DSV, and physician of many elite athletes in football and various Olympic sports. His scientific studies focus on the prevention and rehabilitation of conservatively or surgical treated sports injuries of the knee joint and muscle tendon injuries in professional and amateur as well as recreational sports. He published more than over 100 manuscripts in medical journals, and he presented more than 400 lectures internationally, including live operations and instructor activities. Since 2016, he has been listed amongst the Focus Top 100 in the field of sports orthopedics. Thanks for being with us, Dr. Brucker. And now we come to his colleague, Dr. Doyscher. Dr. Doyscher is team physician at Borussia Mönchengladbach, quite a famous football club in Germany. And he is also working at the Department of Sports Medicine at the Charité University in Berlin. Dr. Ralf Doyscher is specialist of orthopedics, trauma surgery, and non-surgical sports orthopedics. He is full-time team doctor of the German First League Soccer Club, Borussia Mönchengladbach, I mentioned that already, and Dr. Doyscher is specialist in diagnostics, treatment and prevention of muscle injuries, as well as non-surgical treatment of cardiology defects in athletes. One of his main focus in musculoskeletal sonography, as well as ultrasound-guided injection techniques. He studied in Germany, South Africa, and in the US, and successfully graduated with a German as well as a US federal licensing examination. He completed his studies in orthopedic and trauma surgery at the Center of Musculoskeletal Surgery at Charité Berlin. And during his time in Berlin, he worked as a team doctor at FC Union Berlin, Füchse Berlin, as well as for several German Olympic Federation and national teams. So, two amazing gentlemen will now present the role of modern injectables in high-performance sports like football and skiing. So, ladies and gentlemen, I will stop my share screening, and the stage is now yours. Welcome, and take the virtual stage for your presentation.
So, thank you very much. So, a warm hello from Mönchengladbach from my side. Thank you for the very nice introduction and the kind words. So, Peter and me decided that I will start first because unfortunately I will have to leave the session directly afterwards because of the team training today. So our main topic today is injectables in treatment of sports injuries. And as you all know, there are a broad range of devices coming up the last years for treatment of muscle and tendon injuries, especially in soccer and other high-level sports like elite skiing. So, and I'm very proud that Peter joins me for this session to share our experiences with these new kind of treatment options that are coming up. So what we are talking about, so first of all, the disclosure. So talking for myself, there's no conflict of interest with any companies. There's, of course, several memberships in clubs and professional societies. And of course, also for Peter, I think, because he's working for a couple of companies, but there's no conflict of interest for the presentation today. So we are talking about indications for several injection therapies. So there are like two main topics that we are talking about. First is that these injections can help us with the diagnostic of injuries, especially the localization of the origin of pain and malfunction. And then on the other hand, there's also a therapeutic effect that we can not only do like a localization of the problem. So when we do an injection there, we also can help the tissue to heal more properly. And therefore, there are lots of indications like tendon and muscle injuries, like tendinopathies, that are like irritation of the tendons. And of course, all the broad range of osteoarthritis. To do a very gross classification of these injectables, then on the one hand, we do have the synthetic drugs that we all know for a very long time, for like decades. Some of them are on the market for more than 50 or 60 years, especially corticosteroids, but also the non-steroidal anti-inflammatory drugs like ibuprofen or Voltaren. And then there's hyaluronic acid that we know for like more than 30 years now. And then there are also another class that's not synthetic, but it's from a natural origin. That's herbal drugs and homeopathic products. You know them like Traumil or Seal, that's low-dose phytopharmacals. And then we do have for upcoming for the like the last 10 years, the so-called orthobiological preparations. That means like blood-derived products like PRP or ACS, but there are also like stem cell therapies coming up the last years. So it's a very interesting topic, and there's lots of new music coming from that. Why do we need these new classes of medication for our injection therapies? So I will give you a short example that also explains the way of mode of action and also how healing processes in our body can occur. So if you put non-steroidal drugs into a body that has a muscle injury, then we do see some effects that you don't want to have in a healing procedure. So that's the data from the laboratory, but there's also data available now for clinical results. So we see an inhibition of satellite cells. You know, that's the type of cells that the body needs for reparation of a muscle injury, but also for adaptation of the muscle to a training stimulus. So these satellite cells are inhibited, so their proliferation is stopped, and also their fusion and their differentiation. And we will see an impaired muscle regeneration under these drugs, and also an inhibition of the training adaptation. So you have to tell your athletes that if they use these drugs, and they are very common used, if they use it before the training, so then they will mess up their training adaptation and their training success. So that's an information that's not available on each club, and it's not aware to every high-level athlete. So I'm talking about this topic like every week to patients, and I think it's very critical. And we do know also the mode of action, why these non-steroidal drugs are influencing this muscle regeneration. And we know that for muscle regeneration, there's a orthobiological pathway that's from the arachidonic acid and the prostaglandins, and that's a part of inflammation, of an inflammation process. So to make it very easy, with every regeneration and every healing process, there has to be an inflammation. So there's no healing without inflammation, but there's inflammation without healing. So, and if you're going to suppress these inflammation pathways, then you're also going to suppress, at least to a certain degree, you're also suppressing the healing process. And that's one of the reasons why we need other drugs and other preparations to help the body to heal more effectively. We also see that, especially in treatments of tendon, if you expose them to these non-steroidal drugs, you will also find that the structure of the tendon is going to decrease, and you will see a decreased pull-out forces after reconstruction surgery, and you will also find deficient collagen fibers. And so if you go deeper into these molecule pathways, then you will also find the same arachidonic, prostaglandine, inflammatory pathway that's impaired through these drugs, leading to these deficient collagen synthesis. And also the corticosteroids that we all thought might be the most effective weapon that we do have for inflammation and pain relief. We do have data from the last 30 years for these drugs, and we see that yes, we'll find short-time pain relief, very effective, but not for longer times. So it's a short-time effect for like 3 or 4 weeks, and then the pain and the problems will come back. We see a high risk in patients with diabetes. And we also see that there's no clinical superiority compared to use for non-steroidal drugs or the new biological ones. And, if you use these drugs directly with an injection on the ligaments, you will find necrosis, and you will find very, very extreme inhibition of collagen synthesis that can cause to a tendon rupture and to a weakened tendon for a very long time. So nowadays we really try to not use any corticosteroids locally for tendons. So, and then like for 10 or 12 years ago, it started mainly in the United States and the Anglo-American speaking countries. The doctors try to treat these kind of problems, injuries and overuse conditions of tendons and muscles with blood-derived injectables. And then there's a whole big family about these drugs and preparations. And I just wanted to give you a short overview. I think the most common one and the most known one is the PRP, the platelet-rich plasma. That means that the whole blood sample is centrifugated, normally not only once but twice. And then you will get different layers. And the upper layer, normally with the serum and the platelets, is then separated and can be used for injection. But then there are also other ways to treat these blood. For example, with an incubation at a body temperature for a couple of hours, simulating an injury for the body, and the platelets and other cells will start to do all the processes that they also will do in a normal injury. So they will start to build all the cytokines and signaling pathway proteins that we need for the healing process, and will also start start a synthesis of the inflammatory modulating drugs. And then we can also separate this and use for injections. And to just give you an example how these preparations can vary. So the PRP, the platelet-rich plasma, that's not a certain defined drug. So you take a blood sample that can verify itself, and then you're going to do several mechanical steps to treat it, to get a more concentrated platelet serum. And it can differ in the concentration of the platelets by like 5 to 10 times, even if you take the same sample from the same patient on the same day. And so it's almost impossible to get a standardized sample. And that's, I think, one of the reasons why the effect of a PRP injection is not that precise like a synthetic drug, and it's not that easy to make a prognosis of the effectiveness. I talked about another way to treat this with an incubation. So there's in Germany we do have one company that's offering it, and the product is called Orthokine. So you do an incubation of the whole blood for like 9 hours, and then you do a centrifugation, and you try to separate the serum from the rest of the blood contents. And then you get a very thin and very concentrated serum with all these proteins, with all these signaling proteins that you can use. And so from my experience, this is the preparation that gets most close to the effectiveness of corticosteroids in meaning of a very short effect and very early effect on inflammation, but it's lasting much longer than the synthetic drugs. But on the other hand, you have to use it for several times, so it's not enough to do one injection. You have to do like 3 to 4 injections, sometimes 5 injections. So here you see a literature from these type of blood clot secretome in comparison to PRP in 123 knees with osteoarthritis, and Peter will talk about this later. There were 2 arms, one arm with the blood clot secretoma and another one with the PRP. So in both arms received 2 injections per week for 3 weeks. So you see it's 6 injections in every arm. And so the WOMAC score, that's a score for pain and function, and biomechanical analysis were done. And what we saw is that the BCS group was doing significantly better in all parameters. And if you had a look to the synovial fluid, then you saw that maybe one of the reasons for this is that the interleukin-1 receptor antagonist was expressed many times higher than in the PRP group, and the pro-inflammatory interleukin-1b was much lower. So one example from my clinical work. So this is a professional soccer player from our team who suffered a severe medial ligament injury of his ankle this summer. So you see the pictures of the first day on the very left side. You see the deltoid ligament is completely ruptured, and there were many colleagues recommending surgery, but the player refused to undergo surgery for this and asked for a non-surgical treatment. So we used a series of BCS injections, so there were 5 injections on a weekly basis, so for 5 weeks. And then you see the result like 3 weeks after that, after the first injections, and 9 weeks after it. And so the player returned to full team training after 3 months, which I think without surgery for such a severe condition, that's a very good result. So thank you very much. I will hand over to Peter, who's going to give you some more deep insights about his work and also about how to use these blood-derived treatment options for knee injuries. Thanks.
Yeah, well, thank you so much. Also welcome from Munich. I will go ahead because otherwise we may run out of time. Just give you some information because what is about these biological injections? Are they allowed in high sports medicine, yes or no? And indeed, they are just be allowed since 2011 when the PRP was removed from the doping list, from the WADA doping list. So the release for local injection treatment of these injectable is okay, but it's not okay for systemic treatment. So you cannot use these injectables for IV injection. That would be forbidden according to the WADA. Can you go ahead?
Oh, sorry. Yes.
And I think in most of the team doctors' daily practice, I think this has changed, I think the last maybe 10 years. So if you look at in professional sports, we have like maybe 3 bases where we can get to a maximized effect in terms of treatment results. So you, of course, you have on the left side, the conservative non-invasive treatments. You have the, I would call it micro-invasive treatments like needling and injections, what we're talking right now. And you on the right hand, you have the surgical and minimal invasive approaches. And these are all according to the doping rules on the WADA. So my way. Can you go ahead, Ralph? Yeah, thanks. Go back. So before, when I started with these injections, I enhanced a lot of my needling and injection part, and I reduced a little bit my surgical and my minimal invasive arthroscopic treatment, and also my conservative treatment, because we have found now since 2011 this support because of the doping regulations. We can use it right now. And this has changed my daily clinical practice with sports athletes in a dramatic way. Okay. Just give you one example, and interestingly, I will show you my example. So I will show you what happened to me and how I try to include this information and maybe this experience, what I had in my own practice and in my own treatment. So what you see exactly, this was at the German team physician or and doctors championships in Balderschwang, and there you can see exactly, this was a picture where I ruptured my ACL. Okay. And this was my diagnosis. You could see a completely ACL rupture with an undisplaced posterolateral tibial head fracture, including a bone bruise. And I have a small cartilage defect. And at that time, I was thinking doing surgery or not. And at the time, my career in the university clinic in Munich was like just before getting my PhD thesis or my habilitation. So next. I was really thinking doing surgery because ACL surgery is my most performed surgery, and I'm absolutely sure that this surgery usually would help. But at that time, I didn't have enough time to do like the post-op rehab. So I decided, and I know that when you go conservative, then you still have maybe a little bit less therapeutic treatment, which is necessary. I will tell you that later. But of course, when you think about what happened to my stability, to my stable knee or unstable knee, and do I get a COPA or not? At the time, I really decided to go for a conservative treatment because I thought that there is some evidence at that time, at least for me, to go conservatively also, and with a successful overall result. And how did I optimize my conservative treatment after my ACL rupture? I did some kind of limitation of an AP translation of what I used. Okay, can you show the picture? This is a special kind of a brace. It's called ACL reverse brace. It's not a normal brace. It has some kind of a feather, which overall reduce your tibia back to and try to avoid an anterior translation during daily activities. So this gives you a mechanical limitation of a pathological AP translation. And of course, I tried, and I thought maybe I can enhance my healing process with a PRP. And at that time, I used like the ACP, the platelet-rich plasma. You can see where I try to get some blood, and a colleague of mine directly injected into the ACL area, which you can see. So this is original picture at the time. So it's now 9 years ago. Okay. And there you can see my individualized treatment regime. You can go ahead, Ralph. Yeah. So this was some kind of a unloading with this brace. I try to minimize my AP translation as far as I can. I did 2 injections of the PRP after 4 weeks and 8 weeks. And then I tried to do a really like a little bit of slow rehab, not to start too early, to give the ACL enough time to get stabilized. Okay. And there you see, it took a little bit longer, maybe it was about 8.5 months to go back. And then I did a back to sports test, like a functional sports test performance. And then I will go back to skiing. Okay. So there you can see the MRI sequelae. Can just go down, Ralph? Yeah, so you can see I already had a pre-trauma MRI because this was a study MRI to another topic. And there you can see in the T1 and T2 sequence, the trauma, where you can see directly the ACL rupture, and following 4 months and 8 months. And I also have one then 2 years later. And there you can see that the ACL will directly, and it seems to be that it's completely healed. And if you check it mechanically, next slide. There I have a 1 millimeter side-to-side difference in the KT1000. The Lachman test is qualitatively not as firm as on the other side, but the pivot shift is negative. And from that time, after a recovery, I still had no instability signs, no giving way. And now for 9 years, a clinically asymptomatic me, and I still do skiing and football from my personal side from a high level on a leisure level. Okay, go ahead. Just give you one more information. If we look at the injectables like the orthobiologic and the synthetic one, there are more and more evidence coming out that usually the synthetic one are mainly a little bit less successful than the other ones. Sometimes the differences are not so high, but what's the difference? You can use, for example, we know that we can only use corticosteroids only for maybe 1 or 2 times, but these biological, you can repeat and repeat if necessary, and you can tailor it from an individual part. So if you see like big clinical data, there you see that, for example, hyaluronic acid and PRP, that usually like some scores are not different, but in some subscores you can see a better results in the visual analog score and the IKDC, and also biomarker usually developed a little bit better when you use biological than compared to synthetic injectables. Just give you the last slide, give you some overview in terms of what is necessary to know about these biological injectables in professional sports. It is according to the WADA, which is very important, but only use it locally and not systemically, which is very important. And we can see it is effective, but usually it is not a fast treatment. So sometimes, you know, we use a corticosteroid, after 1 or 2 days, all the symptoms are gone, but the healing is not gone, and the healing sometimes just stopped. So these biological gives you an effective treatment option, but don't forget that the time is necessary to still give the body the time to heal. On the other side, usually so far, we have seen really low side effects profile of these biologicals. And compared to the NSAID, we see usually almost no negative effects on performance. And when you use these biologicals, you also don't have to break your training and your competition cycle for a long time. In some other synthetic treatment options, sometimes you have to stop for a long time. And overall, you have a really low risk profile. So I think in the last 10 years, we have made big success, but we are not the end. Still, these biologicals have to get a little bit better optimized in terms of enhancing the biological healing process and focusing a little bit more on the normal natural healing. So this is from Winston Churchill. It's not from us, but I think it seems to be that this is the way, but and there is really true that success is not final, and failure is also not fatal. It's the courage to continue that counts. Thank you so much.
Dr. Doyscher, Dr. Brucker, amazing insights. Thank you so much for your time. I know the time is tight. We have lost a bit of our, let's say, kind of lunch break, but as we don't have a virtual lunch break, so it's okay. I think the insights were so valuable for all of us that it's okay that you are a bit out of time. But I want to use the time also for a question at first from my side. I mean, I'm also an avid skier and I'm active in different kind of sports, and I have always some injuries. But what would be now the difference? I mean, you showcased your problem with the ASL, and at least with the surgery, you would be perhaps faster again on the ski, but the healing effect wouldn't be as good, right? Or could you elaborate a bit about that?
Well, the question is always what is faster. I don't think so that my conservative treatment is a faster treatment. But on the other side, we know from surgery, we have some failure in surgery, but we have also some failure in conservative treatment. And the difference is that if my ACL fails now, then I know I have the first surgery. But if you have a failed ACL reconstruction once again, then the second surgery and maybe the third surgery, this is like a big step, and this is much, much more difficult. So at least we are trying now to avoid maybe the first surgery. Also, we are going not only to reconstruct the ACL with some tendons, we also do some kind of a ligament bracing, that we, for example, do some at least more minimal invasive surgery, that we leave the ACL even if it's ruptured, but we enhance and brace it with some really thick and really stiff fibers. So we try to get in the first surgery, if necessary, more and more less invasive, that in case of a revision, we have an easier procedure, not only for the surgeon, but also for the patient. And I think from my point of view, when you also look at the costs, I think my treatment was probably, and also from an economic basis, much more cheaper. Yeah. I don't want to say ACL surgery, because then I will lose my job. But I think we have to pick the right patients with the right indication. Some people we can do conservatively, and some we have to do operatively.
So it's sometimes also an individual thing how you act with these biological injectables. Yeah.
Absolutely.
So
yeah, you're right.
Okay. So it could be that is there a time where you say, okay, now I could see directly there is an effect coming, or I have to go to a surgery because I can't see the effect. So in the first part, you showcased your PRP treatment, and are you monitoring that? And after 2 weeks, you could then decide, oh, I have to go back to surgery.
No, that's one problem, what we have in conservative treatment. If you look at ACL, we cannot say after 2 weeks, one patient go like with a successful coper, who will adapt to this situation, and one person after 2 weeks who have to get necessary surgery. So that's one problem, and that's the reason why a lot of patients decide for surgery, because then they have this time schedule. That means surgery, and then maybe 8-9 months I will come back. In conservative treatment, you have to go through maybe some months, maybe 3, 4, 5 months to see if it's working. And if it's not working, then you lost time, and this is maybe not acceptable for all patients, especially not in professional sports. Therefore, we have to go directly to surgery.
Okay. So thank you so much for your time. If we have further questions from the audience, I would say they should send you. They will send us an email, and we will forward the email to you. It would be brilliant if you could answer them. Thanks so much for being with us. And you have to run now, Mr. Doyscher. You have to run to the training, right?
Unfortunately.
Thank you for joining us, Dr. Brucker. Greetings to Munich, and thanks for being with us at this first virtual Medica Medicine Sports Conference. Thank you. Bye-bye.